remote lockdown edition. Our focus for the next 2 hours is going to be on antimicrobial stewardship in the setting of the COVID-19 pandemic, and trying to kind of get to grips with the impact that this has had on our overall stewardship activities, both to the good and to the bad. And we have a great panel lined up for you this afternoon. We'll be starting with a talk from Tim Rawson from Imperial College London on co-infections in antimicrobial antimicrobial stewardship in COVID-19, followed by Nuala O'Connor with the community aspects of antimicrobial stewardship, and then Mary Philbin on the hospital aspects. For those of you who are I suppose at this stage most of us are very familiar with using Zoom and similar platforms. We would encourage you to please use the chat function throughout, and if you have any questions for any of the speakers, please put them in the chat function. When you're putting things in the chat function, please make sure that you send it to all participants so that we can all get to see them. We'd also ask you if you've got any specific stories or examples of things that have happened in relation to antimicrobial stewardship in the setting of COVID, that you also share those within the chat function as well. And we'll be coming back to these questions and coming back to your sort of stories and examples in the open forum at the end. So we'll start with our first presentation is from Dr. Tim Rawson. So Tim is an honorary research fellow at Imperial College in London, and he's also a junior doctor at Imperial College. So he's very much in the front line dealing with COVID and antimicrobial stewardship aspects. So Tim, we'll hand over to you.
Thanks so much. So it's really nice to be here today, and this is one of the first times I've done a virtual talk. So hopefully things will all stay in line, and we won't have too many technical issues. So my name's Tim. I work at Imperial College as an honorary research fellow with Alison Holmes Group at the Health Protection Research Unit for Healthcare-Associated Infections and Antimicrobial Resistance. And I also work for Imperial College NHS Trust. If we just go to the next slide, please. I've got no conflicts to declare, and really what I wanted to do today was try and give a bit of an overview of the current evidence and potential gaps in the evidence around co-infections in terms of bacterial and fungal co-infections in COVID-19, and really leave things open, hopefully, for a bit of discussion at the end and as to look in a bit more detail at some potential aspects there. So if we go to the next slide. So I don't really need to go through the background to coronavirus in too much detail, other than to say, obviously in early December 2019, there was a cluster of pneumonia of unknown etiology in Wuhan, China, which was subsequently identified to be novel coronavirus 2019 or COVID-19. And we've really had to learn on the spot with this as we began managing patients with COVID. But it's become apparent that there's a spectrum of diseases and a probable number of phases of the disease which we're seeing and having to manage, all the way from simple upper respiratory tract-like symptoms through to patients developing hyperinflammation, really severe ARDS-like type pictures with horrible bilateral multilobular consolidation requiring mechanical ventilation and respiratory support for long periods of time on critical care. And even in the early emerging evidence, it became apparent that it was going to be quite difficult for us to be able to differentiate what is just an underlying viral infection and cytokine response to whatever's going on in terms of the pathophysiology of COVID, as opposed to a bacterial or fungal co-infection. We were seeing patients with typical symptoms, imaging which could be or couldn't be consistent with bacterial or fungal infection, and significantly raised inflammatory markers, which we use routinely in practice to make decisions around antibiotic prescribing, for example. But interestingly, even from the early literature coming out of China, it suggested that the rates of bacterial and fungal co-infection within the initial COVID-19 cohorts was fairly low. And unsurprisingly, use of empirical antimicrobials in acute care was high. So if we go to the next slide, please. It got us really thinking about what are the potential challenges for stewardship in terms of the response to the COVID-19 pandemic. In particular, as we are beginning to expand hospital capacity to deal with the high burden of cases of COVID-19, it was causing a huge amount of disruption to routine healthcare infrastructures. And when you put this into the context of the challenges of being able to differentiate a pure viral from a viral and bacterial co-infection, and the apparent rates of high empirical antimicrobial use, it was really becoming clear that there was going to be a challenge there for us, especially as it was so unclear in terms of what is the attributable rate of co-infection with bacterial and fungal pathogens within this cohort. So two questions really sprung to mind early on as we were learning more and more about COVID-19. First and foremost, how is this actually going to impact on antimicrobial resistance in the long term? And secondly, how are we going to be able to maintain access to effective therapy for individual patients who do require access to antimicrobials? So if we go on to the next slide, please. In terms of the impact of COVID-19 on antimicrobial resistance, I think depending on what setting you're working in and what your sort of experience of COVID's been so far, it's quite easy to focus just on the pure negative factors of COVID-19 on the long-term impact of antimicrobial resistance. But I think it's important for us to try and take a balanced view and consider whether there are some potential positive factors also which will come out of this. I'm not going to go through all of these in particular detail, but just to summarize, in terms of potential positive factors with AMR, there's obviously been a huge increased focus in the media and the press and public appreciation of infection prevention control measures and things such as hand hygiene. We're beginning to see individuals try and physically distance from each other. We've seen patients who would normally present to healthcare trying to avoid it because of concerns around catching COVID-19. And also, we've seen, especially in the NHS, reductions in routine healthcare being delivered. And actually, in certain areas, we've seen reduction in chronic healthcare patients in hospital, and therefore reduction in carriage of chronic multi-drug resistant organisms within certain settings. Also, due to a lot of the media around this being a viral infection and avoidance of healthcare, there was a question of whether there would be a potential reduction in antibiotic-seeking behaviours, and overall whether we could expect to see a reduction in community antimicrobial prescribing, which potentially could all have a positive impact on AMR in the long run. Similarly, there are a wide range of potential negative factors you can identify in terms of COVID-19. First and foremost, it was expected we were going to see a huge increase in empirical antimicrobial prescribing, particularly at the front door in acute care as patients come in with these, serious clinical signs of infection, bilateral chest X-ray changes and raised inflammatory markers. We were also beginning to realize that with the disruption to our routine healthcare system, we were going to be able to offer less opportunities to isolate patients with other infectious diseases, which we normally would. And this combined with things like healthcare overload and diversion of PPE could all potentially have a negative impact on the transmission and development of AMR. There are also a number of potential questions that were unanswered. We were beginning to move towards more types of remote medicine, such as telemedicine, and there's very little evidence around the impact that has on things like antibiotic prescribing. And in terms of organizational and sort of larger national programs, there was also the potential that the disruption to healthcare team infrastructures would have an impact on antimicrobial stewardship teams and programs. And also we may see disruption in things like long-term preventative measures, such as immunization. So if we go to the next slide, please. So really the first question that we wanted to ask was, is co-infection common in this cohort of patients? And really the main concern is that in previous respiratory viral pandemics, such as influenza, there's been a strong association of mortality with different bacterial and fungal co-infections. And I've just listed a few of the causative pathogens which are associated with that through different pandemics. But really for different coronavirus infections, not just COVID-19, there's very little data currently to describe the rates and types of bacterial and fungal co-infection which are observed. And therefore, there's very little evidence to help support antimicrobial prescribing and recommendations within this cohort. So if we go to the next slide, please. So quite early in sort of the middle of March, actually, we began to look at this, and we decided to perform just a rapid review of the literature to try and understand, not just for COVID-19, but for other coronavirus infections, what their reported rates and types of organisms being identified as causing bacterial and fungal co-infections were. Now, at the time, it became quite clear that the data was so heterogeneous, there were so many potential sources of bias that really it didn't lend itself to doing something like a systematic review. And also, we felt that we only want to try and identify studies where bacterial co-infection was actually reported and identified, accepting that that wouldn't allow us to estimate a true rate of bacterial and fungal co-infection within the population at present. And after a sort of a number of different searches, we identified 18 studies, half of which were related to COVID-19, which was already in sort of middle of April by the time the search finished, and the other half related to other coronavirus infections, the predominant ones being SARS and MERS. And interestingly, of the COVID-19 population in isolation, so the 9 studies reporting COVID-19, we were able to identify 806 patients in studies reporting detection of bacterial or fungal co-infection. And of these 806 patients, 62 or 8% were reported as having co-infection. Unfortunately, from this data, it's very difficult to pick apart. There was very little microbiology actually reported. And most studies didn't differentiate the setting or even at some points the actual site where the bacteria or fungi were isolated. So for example, a mix of critical care and non-critical care patients. Similarly, for non-COVID-19 patients, there was the rate of bacterial and fungal co-infection reported in similar studies of about 11%. And I'm not going to focus too much on the non-COVID-19 section today, but it's something that we can perhaps pick up a bit later if it's of interest. So if we go on to the next slide, please. So here I've just tried to break down the studies which reported bacterial and fungal co-infection in COVID-19 patients. And the figure basically just shows the percentage of patients within the reported study who were identified as having a co-infection. And it ranges, the studies varied in size from a couple of patients being reported up to a few hundred. And the rates of co-infection per study ranged anywhere from about 2% to just over 15%. And 3 studies I just wanted to draw your attention to were, first of all, Zhu et al., who actually overall of a population of about 200 patients reported from China, identified a secondary infection rate of 28 out of 191 individuals who underwent sampling, which was about a rate of 15% of bacterial co-infection. Interestingly, actually on admission, about 150 of their patients, just less, actually had procalcitonins performed, and about 88% of them, had low procalcitonin, suggesting that on admission, there wasn't a high proportion of patients presenting with co-infection. But the key messages to come out of this study were that of the 28 individuals with a co-infection, 27 of them went on to die. And of their 32 patients in critical care who underwent intubation and mechanical ventilation, the rate of ventilator-associated pneumonia was high at 31%. In terms of the other 2 studies, I've just pulled these out just as examples. Goyle and colleagues was probably one of the largest studies that was reported. And although they didn't provide any data on microbiology and mix in terms of case, they actually reported a bacteremia rate of 6% within a cohort of 338 patients admitted to a hospital in the United States. And equally, Chen and colleagues is, I think, quite an interesting study from the point that they actually performed respiratory sampling on patients on admission to hospital on all 99 patients. And so they report the rate of co-infection identified essentially at the front door with patients giving sputum samples for microbiology and mycology. And here they report a co-infection rate from these samples of 2 out of the 99 individual patients, one of which was actually just a Candida albicans, which was identified in the sputum. The second patient had a resistant gram-negative and a Acinetobacter, and also had an Aspergillus in their sputum, and both were treated for these, along with the vast majority of the other 99 patients in the cohort. If we go on to the next slide, please. So overall, the reported rates of bacterial and fungal co-infection within the literature was fairly low, at about 80%. But in terms of the rates of antimicrobial prescribing, this was significantly higher. And so for this, we actually ended up identifying all studies in the literature which reported antibacterial or antifungal prescribing, regardless of whether or not they identified or reported microbiology or bacterial or fungal co-infection. And I've just graphed them again on the right of the slide here. And once again, the number of patients per study varies, but in terms of the larger studies, we found that almost 60% of most large cohorts reported in the literature of patients were actually receiving antimicrobials. And when we took the total number of patients, we had about 2,010 patients reported, of which 72% received antibacterial treatment during their inpatient stay in hospital. The majority of this was broad spectrum in nature. And once again, most studies didn't differentiate between the setting of where antibacterials were prescribed, whether this was in critical care, whether this was on admission to hospital, or whether this was someone on the general medical wards. But interestingly, we saw repeated themes, and I've just highlighted this here through Kao et al.'s study, who reported of the majority of their patients who received treatment in the study, about 85% of individuals were prescribed a quinolone, and about 1 in 4 patients received a carbapenem during their inpatient stay. And very finally, I just wanted to highlight the sort of probably the most robust study we have at this point to actually look at rates of prescribing, and this was a study by Guan et al. So this actually took about 14% of all Chinese reported cases of COVID-19 at the time, which was about 1,099. And as at the time the study was reported, about 58% of their patients had received an antibacterial and 3% received an antifungal. Unfortunately, this study didn't report any co-infections, and actually none of the studies reporting antibiotic prescribing or antifungal prescribing reported anything to do with adverse events or complications of therapy, which I think is probably another interesting area which is significantly underrepresented in the literature at the moment. So if we go on to the next slide, please. So that's where we sort of left it, and our study was published in CID in, I think, early May now. And since then, there have been a number of other publications which have supported some of the findings we made and also asked a number of other questions. And I just wanted to give you 3 examples of those very briefly. First and foremost, Lansbury and colleagues, who are a group from Nottingham University, actually undertook a systematic review and meta-analysis of looking at co-infection in patients with coronavirus. So they actually tried to look at all studies and report the absolute rate of reported co-infection within the literature at present. And they found that that was about 7% in terms of bacterial co-infection in reported cases to date, with it increasing to about 14% when you take studies that only report critical care patients. And that was only 3 studies, I think, out of all the 30 they identified in their literature review. Interestingly, also, viral co-infections has been reported as low at present, about 3%. And again, the rates of antimicrobial prescribing in general were high across all cohorts. The authors also tried to represent the rates of the proportion of bacterial co-infections, which is the top graph represented on the side here. And it's difficult to interpret this, though. I think there was, out of all of the co-infections they found, there were only 27 individual patients reporting co-infection, and the majority of patients, about 40%, had Mycoplasma pneumoniae. However, this was diagnosed by positive IgM rather than prolonged culture. Following on from this, we've also had further updates from China, which are, I think, of interest again. The Chinese National Pharmaceutical Association recently released work which has reported a 10% overall bacterial co-infection rate for all patients with COVID-19 nationwide. And this was reported to have rose to 31% in patients who were admitted to the intensive care unit. This has been supported by a recent study published in Critical Care by you and colleagues, who reported a summary of all COVID-19 patients managed in intensive care within Wuhan district during the initial months of the outbreak. And once again, they report about a 21% rate of bacterial co-infection, 98% of which were diagnosed as hospital-acquired pneumonias. And you can see from the bottom figure here, reported organisms which were identified with carbapenem-resistant Acinetobacter being the predominant organism that they identified within their cohort. So if we go to the next slide, please. So that's where we are in May, and evidence has been reflected really in the World Health Organization's interim guidance around COVID-19, who have essentially recommended, in terms of empirical antimicrobial prescribing, that when there's no evidence or clear evidence of bacterial co-infection, it should really only be considered in patients who have a severe COVID-19. And in terms of their more global advice, I think they take a really strong stance in terms of recommending that it's a priority to ensure that antimicrobial stewardship programs remain or are put in place to deal with the expected high rates of empirical antimicrobial use within acute settings. And supporting the use of short course duration antimicrobial therapy, and a real focus on the potential long-term consequences of overprescribing within the COVID-19 pandemic on antimicrobial resistance and individual patient adverse events such as Clostridial infection. So if we go to the next slide, please. So that's really where we are in terms of the evidence and the data at the moment. And I think that the more we begin to see in terms of evidence around co-infection in COVID-19, it's clear that it's actually probably a lot more nuanced than whether or not someone has an infection, yes or no, on top of their coronavirus infection. I think that you could suggest at the moment that it looks like at least we're identifying more bacterial co-infections in sicker patients who tend to be on critical care. But I think that we also need to take a number of other considerations into account when we begin to design studies and look at this in more detail. First and foremost, in terms of the co-infection, we really need to be able to try and differentiate what is actually directly attributable to COVID-19. So is COVID-19 facilitating the increased virulence of source-borne organisms as we see in other respiratory viral infections? Or are we seeing co-occurring infections in patients who also test positive for COVID-19? Is this someone who has a urinary tract infection or a bloodstream infection that also happens to have COVID? And finally, are we seeing high rates of infection because patients are developing secondary infections caused by healthcare exposure? Is this patients who are spending long time in intensive care on ventilators and have a number of risk factors developing healthcare associated infections, as do other patients in this situation? And then not quite as sort of not on the same topic, but I think almost as important for us to consider in the back of our minds while we're thinking about trying to define co-infection in COVID-19. It's also important to consider how we continue to deliver access to treatment for patients who don't necessarily have COVID-19, but have bacterial or fungal infections and require appropriate therapy when we're so focused on the problem of COVID-19 because it's so prevalent within our population at this time. So if we go to the next slide, please. So this is a study which is fairly hot off the press. I think it's come out in CID today, which was actually a report in response to some sort of one of the papers we published in CID regarding bacterial co-infections. And it's a French study looking at 54 patients with moderate to severe coronavirus who were admitted to an intensive care unit in France. 45 of which underwent indirect bronchoalveolar lavage, and it reports a high rate of identified bacterial co-infection, with 20 of their 54 patients having significant growth, and the majority of these individuals being diagnosed with late ventilator-associated pneumonias. In terms of rates of prescribing, about 65% of their cohort received antimicrobials, and they had fairly long periods on the ventilator. So the median interquartile range of ventilated cohort was 12 days with 7 to 21 IQR. And from this study, the authors highlight a number of key issues. First of all, the need for more standardized methods of respiratory sampling if we're going to try and identify and define a true rate of co-infections within different cohorts. And also they highlight the fact that in certain settings, the rate of co-infection may actually be higher than the 8 to 10%, which is being described across everyone with coronavirus. So if we go to the next slide, please. And I think this raises a really important point when we think about co-infection and trying to understand the nuances of it. If we look at our pre-COVID-19 era, and we look at the rates of things like ventilator-associated pneumonias, for example, we see that the stated rate normally of VAPs in critical care is anywhere between 9 and 27%. And when you begin to look at the risk factors for ventilator-associated pneumonias, you begin to see a lot of common themes which are common to many of our patients with coronavirus. So risk factors include, but aren't limited to, things like prolonged ventilation, long periods of paralysis, male gender, as well as acute respiratory distress syndrome. And if you look at the large cohort studies around critical care patients, such as the ICGP database, you'll see that these patients match these risk factors quite strongly. Particularly in terms of male predominance, requiring long periods of ventilation. And in fact, due to the requirement for lung protective ventilation to try and prevent patients' self-induced lung injuries on the ventilator when we allow them to take spontaneous breaths, we're also finding that we're having to keep these patients, especially the sickest ones, paralyzed for much longer periods of time than we do routinely with patients in critical care. And I think also it's important to note that this increase in rates of things like VAPs isn't isolated to COVID-19. In fact, during previous coronavirus pandemics, such as SARS in 2003, there were similar reports then by colleagues from Asia. So Yap and colleagues, as an example, reported in 2004 on 83 patients in their intensive care unit within Hong Kong. And during this period, they experienced higher rates of ventilator-associated pneumonias, with 30 episodes within 83 patients. These were with similar types of organism, which are associated with their healthcare-associated infections and ventilator-associated pneumonias. And also they experienced significant increases in antibiotic prescribing within that cohort in intensive care. Again, focusing on the cephalosporins, the quinolones, the carbapenems, and in this case also glycopenicums. So if we go to the next slide, please. So that's bacterial co-infections within the critical care setting. And I don't want to spend a lot of time on this slide, but I just wanted to include it, to share it as another point for talking later and for some future thought. And that's the role of invasive fungal infections within COVID-19. And I think if we're honest at the moment, they're still rarely reported, but it's true that they may be being underdiagnosed and need careful consideration. In terms of risk factors, we know that COVID-19 and ICU patients share a number of risk factors and underlying conditions which are reported in invasive fungal infections. We have seen, in terms of incidence, reports of quite high rates of putative IPA in patients, particularly on critical care. And the mortality is still unknown, but if it's anything like influenza, the concern is that it may have a significant impact on mortality in your patients with coronavirus. And one of the early studies which really alerted us to this was a study from the French ITU, where out of 19 individuals with moderate to severe coronavirus, 26% of them were diagnosed with putative invasive pulmonary aspergillosis. And there's really a nice comment in the Lancet by a number of the European sort of clinical mycology groups, which I've put reference to here on the slide, which I think is worth a read, which discusses this in more detail. But it also discusses the requirement for us to carefully consider when we need to undertake things like bronchoscopy-guided BALs, as well as the requirement for initiating therapy, even when aspergillus is isolated. And that's because through the process of trying to reduce exposure of healthcare workers, we're trying to avoid doing direct bronchoscopies, and we're doing things like indirect BALs and tracheal aspirates at the moment. And although these can help us in terms of diagnosis of aspergillosis, they can also allow us to diagnose contaminant aspergillus. And so really it's a challenge in terms of balancing those risks and benefits of connecting therapy and undertaking extra investigations to really try and diagnose this for our patients on critical care. So if we just move forwards, please. And so I've got two final slides of I just want to not spend much time on it all, but just to bring up, and we'll hopefully follow on in terms of the next presentations and the discussion. But the first one is around community co-infection. And I think to be blunt at the moment, in terms of the literature out there, there's very little data describing co-infection in the community. Where there have been studies looking at patients mainly in the outpatient setting or in individuals that present to the emergency department but aren't admitted, there at least has been no identified sort of atypical organisms based on the screening that's been undertaken, and low respiratory viral co-infection also actually. But there are a number of questions out there which need to be considered, particularly in terms of remote things like telemedicine and how that's going to impact on antimicrobial prescribing, and also the focus on maintaining appropriate access to therapy when required. And that's in line with us seeing reduction in rates of antimicrobial prescribing within the community. And this was a study, a figure on the right-hand side of the screen here, in JAMA recently, which showed that the rates of amoxicillin and azithromycin prescribing within the community fell quite dramatically after the United States declared a national emergency. And although this could have a potential positive impact overall in terms of reducing collection pressure, we also need to consider whether it's going to have a negative impact on individuals who potentially aren't able to access therapy when required. And so if we just go to the next slide, please. So as a final point, I just wanted to touch on a couple of other areas which I think need consideration and will hopefully lead to a bit of discussion later. And when we think about the long-term impact on antimicrobial resistance and how COVID-19 may actually impact more on vulnerable populations. First and foremost, we're now seeing significant reductions in routine vaccine uptake. And even on top of the concerns around increasing vaccine preventable disease, we're beginning to understand that vaccination is probably a key intervention in preventing the future development and transmission of antimicrobial resistance. And so whether actually it's factors like this which are going to have a more significant impact in the long run, it's still something that's up for debate and needs to be focused on as part of future research. Similarly, there's been huge disruption to things like tuberculosis therapy, and the Stop TB partnership have actually reported the impact of stringent lockdowns over even a short period, like 3 months, having significant impacts on their program over the next 5 to 8 years in high burden TB areas. And very finally, we're yet to see whether COVID-19 is going to have an impact in vulnerable populations, including some low middle income settings and in humanitarian areas. And the importance here is that actually where places are under-equipped to actually deal with it, and there's already high burdens of endemic infectious disease. And so it's important for us not just to focus on our own settings within the more high-income settings where we can expand hospital capacity and ventilator capacity and put in place stewardship and guidelines, but also to focus broadly across the globe and where we can have impact here through guiding the evidence. And so if we go to the last slide, please. So I think moving forwards and for future discussion today, hopefully, I thought I would just leave with saying that I think in terms of stewardship interventions, it's important that we begin to focus on designing those in accordance with these observed variations we're seeing across different settings. And as always, it's going to be important for us to engage not just with other stewardship teams and infection teams within the hospital, but more widely with specialists at the front line who are responsible for the antibiotic prescribing within these different settings, to ensure that we design and implement strategies and programs which are acceptable and will be adopted upon implementation. And very finally, I think that I've hopefully shown today that although there is evidence that bacterial infection is low and prescribing is likely high, there's still a requirement for much better data to support the development of evidence-based recommendations for the management of bacterial and fungal co-infections within COVID-19. So thank you very much. I'm happy to take any questions now or pick them up in the discussion a little bit later.
So thank you so much, Tim. I was trying to get my video started here again. That was an excellent overview, and so I think what we're going to do is we're going to leave all the questions until the end to the discussion section. So, but just before we move on to the next talk, I just want to remind people that This conference has been approved for 2 CPD points. So for anybody who is participating in this, it counts as two external CPD points. So just to make sure that you record that. So we move on then to our second talk, which is from Nuala O'Connor. I think Nuala is probably well known to just about everybody online. What you may not know is that Nuala was recently awarded a silver medal for just being an amazing Cork person. But we already knew that. So Nuala is going to move the discussion now to talking about the impact of COVID-19 on antimicrobial stewardship in the community.
Thanks, Rob. So I suppose normally I talk an awful lot about antibiotics and antibiotic stewardship to my colleagues, but I got thrust very much into the limelight as kind of being the only GP who knew anything much about infection control. So I became de facto the ICGP lead advisor on COVID-19, and that's really what has exercised me a lot over the last couple of months. But it's nice to get back to talking about antimicrobial stewardship, and I'm going to do this in the backdrop of what happened during recently with COVID-19. First slide, please, Rob. So I suppose one of the things that really emerged that was different in general practice is actually what we're doing now. A huge enhanced opportunities for virtual engagements with GPs and with those whom I would be trying to influence. So we sent our first notification, which was an email notification to GPs on the 29th of January. And that time we were talking about the emerging picture of novel coronavirus infection. And really, I think when we sent it, we kind of thought it's never really going to happen in Ireland. But since then, with the pace that changed, we've sent over 50 notifications to our members. And we started to do webinars, and the first one was really impromptu. It was on the 17th of March. We'd had lots of GP WhatsApp groups going. There was lots of queries coming in because we'd now had our first cases in Ireland. We'd had a case in Cork, and I think GPs really got, they were at that stage where they were very frightened, and there was a huge thirst for knowledge. And a GP in Castledown-Bear asked me, could we do a webinar about some of the stuff on the WhatsApp groups? So she set up an impromptu webinar on Paddy's Day, and she very quickly, she did a license for 500, and before we knew it, we were oversubscribed. Now, this was only released that we were going to do this at lunchtime on Paddy's Day, and the webinar was at 4 o'clock. So I think the ICGP, a number of members were on there, realized, gosh, maybe we're onto something here. So we started doing webinars, and we've delivered 15 at this stage, and there's over 1,400 GPs every Wednesday night log in. And for our virtual AGM, the equivalent of this, which we did on a beautiful sunny Saturday morning, we had over 1,800 participants who stayed online for 4 hours. So we've realized that we've got a great way in terms of antimicrobial stewardship, a really good way of connecting and a great reach out into those that we're trying to influence. So the way the ICGP works is we have 37 faculties around the country. So they would be with kind of larger groups of GPs. And then that breaks down into, we have small group meetings where about 12 to 15 GPs meet together 6 times a year. And there's about 170 of those groups, which are led by 39 tutors around the country. But they've also had to move to doing this virtually. Along with, we've a COVID hub, we've been doing podcasts, we've produced new clinical guidelines, and we have our usual e-zine and our forum journal, which is a paper journal that arrives. The other thing that we've done is we set up a live Q&A facility. And we garnered together, we've a small core group of GPs, but we also got the university departments, audit GP, and various people who are involved in research in primary care who wanted to help. So they spend their time fielding and answering these questions, and they're all there live for people to do. This was along as well with a strong media and communication strategy from the college. So I suppose what it's done, it's given us a massive increased connectivity to those that we're trying to influence, not just the public, but actually our own members, which was always a problem. Say, for instance, I was working 2 days a week in antimicrobial stewardship, but I can see now moving forward, because there's a real thirst for this online presence, that we may be able to keep that reach going for longer out to those that we're trying to influence with regard to their antibiotic prescribing. Next slide, please, Rob. And I suppose, you know, infection control, these were the kind of things that we ended up being coined for people to remember what they should be doing in the different situations. And I hopefully we will never go backwards in terms of GPs learning about the importance of infection control in preventing the spread of disease, because I think a lot of them paid lip service to this up until recently. And the next slide, please, Rob. So the key messages that we have been hammering home to people is that there's no emergency where you don't stop to don PPE, that the highest risk is from your gloved or ungloved hand, bringing that to your face. Really important that they understand about how to use masks, importantly. And also about utilizing technology to minimize face-to-face contact if it's not actually necessary. But I suppose overall it really is about scrupulous attention to hand hygiene and maintaining that 2-meter social distance. So I've put a few date stamps in here just to show these are slides from various points in time that we were talking about to GPs. Next slide, please. So the key message really with regard to antimicrobial use came when we started getting reports that there were lots of azithromycin requests going into pharmacies, also requests for hydroxychloroquine. We all know that that wasn't an appropriate thing. So we really had to be quite proactive with GPs in trying to explain to them when they might use antibiotics. And it was a little bit difficult because anyone who went into hospital was being put on antibiotics. So I suppose the natural thing for a GP was, well, look, maybe if I put somebody on antibiotics, it's going to reduce the severity of the course of their infection. So we tried to get GPs to focus on only using antibiotics if somebody had an underlying lung disease, where they tended to have a history of getting secondary bacterial infection in the winters. So a lot of our COPD patients, those with bronchiectasis and various things. And the other thing we tried to do is to focus on the quality. So if you were going to prescribe, it was doxycycline and it was for 5 days. Next slide, please. And again, we gave them some tips about how you might distinguish between a viral COVID-19 pneumonia versus a bacterial pneumonia in that similar kind of cohort of patients. And most of that is actually well known to you. And next slide, please. So I suppose the key thing that we wanted to get across to them is do not delay. We had this huge problem. Patients did not want to go anywhere near a hospital. They were incredibly fearful of picking up COVID in hospital. But we know that there was really important that as patients started deteriorated in that second half of the second course of their illness, during that second week, maybe from about day 5 on, that they could nosedive really, really quickly. And we didn't want GPs delaying and getting them to hospital, because the main treatment was then and remains supportive treatment with pneumonia and fluids. And now, as I understand it, that in hospital, all of the antibiotic treatment tends to be as part of clinical trials, or where patients are have underlying comorbidities where you could justify using the antibiotics. And the next slide, please, Rob. So the next 3 slides were, again, just ones that I showed GPs these are Vita Hamilton slides actually from the acute side, just to show GPs all the other types of things that could be done for their patients when they went to hospital, which would help to make sure that they got the most appropriate care. So the following slide. So again, the investigations, and then the next slide, Rob. And this was just to show them that there was an antimicrobial stewardship approach in the hospital, where while they may start antibiotics empirically, that there then was a decision based on test results and based on the clinical course of the patient that the antibiotics actually could be stopped. So these slides I would have been sharing with GPs from mid-April onwards. And the next slide, please, Rob. So then that culminated on the 23rd of April, there was this joint statement which was targeted at community hospital prescribers and antimicrobial stewardship teams, where all the evidence to date which showed that while there was some evidence of bacterial co-infection, this was actually probably much less than there was in viral infections, and the importance of sticking with the recommended treatment, which would be doxycycline in the community, but only for those where they had a pre-existing lung condition. And I think it really showed the importance of a system-wide approach to antimicrobial stewardship, which is really what we're all about here. And we promoted this through antibioticprescribing.ie, which is the community antimicrobial prescribing guidelines. We added some new tiles on there where we could show COVID and also key messages from the AMRIC team. Next slide, please. So I suppose what I'd like to look and try to get GPs to focus on what might be the unintended consequence of COVID-19, and what we didn't want was an increase in antimicrobial resistance and the superbugs. Very early on, we became aware that there was a shortage of co-amoxiclave. So we tried to, and there was an increase in the azithromycin prescribing. So these were things that we tried to communicate to GPs, and we did it via some of our email communications and via our webinars, and tried to explain to them that there was no justification for using azithromycin, reiterated when they should use a co-amoxiclave when it was appropriate, and to get them to focus on the green preferred antibiotics. And I'll explain that to you in the next slide. Next slide, please, Rob. So again, we came back to co-amoxiclave. These were the first line indications which are there for in the community: endometritis, a lot of postpartum related, animal bites, human bites, third line agent in pyelonephritis, and facial cellulitis. And again, we tried to reiterate the other antibiotics that we've been trying to promote, using nitrofurantoin initially, cefalexin for upper UTI, cefalexin in pediatrics as well, tonsillitis if you choose to prescribe phenoxymethylpenicillin, otitis media amoxicillin rather than cefalcore, which was often their preferred one, reminding that for sinusitis it's only about 2% bacterial, and then for lower respiratory tract infection, doxycycline and amoxicillin. We knew already that for soft tissue there has been a huge swing towards flucloxacillin use quite appropriately in most community prescribing. The next slide, please. So we underpinned again, the importance of the principles of antimicrobial stewardship, and you can just hit the next click, please, Rob, which shows, reminding them to go to the website, and click again, please, Rob. Reminding them of the red-green antibiotics mouse bats. And again, you just do the next 2 clicks, Rob, please. So again, the importance of immunization. But I suppose the big key extra thing here is that people really got their role in trying to prevent the spread of infections for themselves and all of their co-workers in general practice, but also the importance of reinforcing this message when they were talking to patients. The next slide, please, Rob. Again, this is the red-green. So we try to get GPs by and large to use the green antibiotics because they'll cover the vast majority of things that they see in general practice, and try to reserve the red antibiotics for those where they were a genuine first-line indication. The next slide, please, Rob. So just to get down to the data, so what we've been doing since September of last year is we've been sending, since just before the summer of last year, we've been sending GPs a quarterly feedback on their GMS prescribing. And we're giving them information on 4 of the red antibiotics. And we're trying to match this with some audit ideas and some educational nudges as we progress, and maybe throw in some patient stories for them. And it's all about trying to nudge them towards more green and less red prescribing. The next slide, please, Rob. So I'm going to give you a little bit of consumption data now from 3 data sources. So the traditional one that a lot of us are looking at is the ECD antimicrobial consumption data, but I'm actually not going to show you any of those slides, because what we've seen in the 2019 data is actually mirrored in the PCRS data. The PCRS data is actually prescription level data for patients who actually have a medical card, and it is the data that is collected when they present that prescription to a pharmacy to actually be dispensed. And that's collated by the PCRS system. And we also have health market research from the IPU, which actually covers private and public prescriptions. So these are prescriptions that are actually dispensed in the pharmacy. So they are better than antibiotic consumption data, but they do mirror what was in the anti-consumption data. The other thing is that the early antibiotic consumption data for the first quarter of 2020 shows a huge increase, which is probably related to stockpiling of antibiotics by pharmacies and doesn't really reflect community use of antibiotics. So the next slide, please, Rob. So here we're looking at GMS prescription level data. So these are the number of items prescribed per 1,000 GMS eligible population. And we're looking at a time series from 2012 up until 2019. So unfortunately, what you can see there is that the rate of antibiotic prescribing has increased. So between 2018 and 2019. And partly the reason for that is that, if you remember, the flu season arrived early last year. So it started at the end of November, it peaked in December, and it was gone by the first week of January. Whereas in 2018, it started during the early part of 2018, and it was around and went down sometime in March. So I think possibly that part of that accumulation, that increase, may be to do with the timing of the flu season, because we know that there's always a spike in antibiotic prescriptions then. And then if we look down at the bottom, but I suppose the point about the green arrow there is that if we do compare the quantity of antibiotics prescribed in 2012 versus 2019, we still have, 455,000 less antibiotics in 2019 than there was in 2012. So that's nothing to be dismissed too lightly. Overall, though, we are seeing a slight increase in the actual number of prescriptions. Again, in the under 16s, where we had quite a significant reduction. If you look at 1473 in 2012 versus 1111 in 2019, there has been a small increase, but some of that may be to do with the flu seasons. Next slide, please. So this now is looking at the IPU data. So this is antibiotics, both private and GMS. And again, this is 2019 data. So you can see that kick up there in December 2019, which we think is probably related to the early flu season. Next slide, please. So now we're going to get to look at the quality of prescribing, because this is something that we've really tried to focus with GPs on over the last number of years. So again, we're looking at a time series here. So each of these color blocks represents, so 2015, 16, 17, 18, and 2019. And we're looking at the different antibiotics. So this is the top 10 prescribed, and then the next slide will be looking at the top 20. And it's pretty much mirrored in previous years by the both private and public. They're fairly similar. GPs don't tend to prescribe very differently for the two populations. So we can see some very positive trends here. So on the left-hand side, you see the reduction in comoxiclave year on year. You can also see quite a significant reduction in the use of clarithromycin. And you can see you have an increase in the use of nitrofurantoin. You have unfortunately, a negative thing is you have an increase in the use of azithromycin. I'm going to come back to that. But you can also see quite a significant increase in the use of doxycycline, which shows that the GPs are starting to follow the guidelines, because this is over the whole of 2019. The next slide, please, Tony. And I think in this slide, so this is antibiotics 11 to 21, and again, the same time series. So I think you can see more dramatic changes here. So you can see a rise in cefalexin, which we've been promoting as the cephalosporin to use if you choose to use one. And you can see a dramatic reduction in cefalcor, which was very popular, you'll see later, for pediatric prescribing, I think because it's got a lovely strawberry flavor. and also reduction in cefuroxime. The other group that I'd like to draw your attention to is if you look at the fluoroquinolones there. So you see moxifloxacin really reduced because we focus very much on that in 2019. Levofloxacin there as well. And ciprofloxacin really has tumbled down in its use in the community. So they're very positive. Another one that's quite positive there is the use of erythromycin, because one of the things that was very surprised me when we started to look at the data was the amount of erythromycin that was still being prescribed in the community. So we've focused GPs on the fact that that really is an antibiotic that is probably of very little use because of poor sensitivities. The next slide, please, Rob. And this would be just an example of the type of educational awareness that we would try to use for GPs. So if they were choosing to prescribe for tonsillitis or otitis media, we're trying to get them to focus away. You see that green spike there, that was the amount of cefalocor, marketed as Distaclor, that was being used in the community. So we really tried to get them to try to substitute with phenoxymethylpenicillin or amoxicillin, or better still, don't prescribe at all. But again, the other thing on this is just to show you is that in terms of overall cephalosporin use, it's the over 65s is where the largest use of these antibiotics come in. Next slide, please. So here we can see again the trends in cephalosporin use. So you can see the top blue line there, which is cefalocor targeting up. And I suppose the big thing here, our message to GPs, was there was no need to use anything other than cefalexin unless there was known resistance, and to avoid all of the cephalosporins in respiratory tract infections and use amoxicillin instead. But again, I just want to draw your attention to the over 65 group and the use of cephalosporins here. Next slide, please. Here you can see the fluoroquinolones very nicely demonstrated is that fall off in fluoroquinolone use in the community, and you can see the kinds of messages that we were using to help influence, reminding GPs about the potential serious side effects of these drugs and the need to really be able to justify why they use that instead of a first line indicated antibiotic according to community prescribing guidelines. But again, over 65s, is there justification for using? There is, from feedback from GPs, and some of them who've done individual data studies, a lot of the prescribing for fluoroquinolones is actually by hospital-initiated prescriptions. So they are just filling out prescriptions which have been initiated in hospital on patients who have attended outpatients or who have been inpatients. So this is one of the reasons why it's good for us all to talk about whether or not those may be appropriate, and is it something that we need to look at in terms of hospital prescribing. Next slide, please. So macrolides, again, we focused on the safety messages with these. Some of the azithromycin increase, maybe that probably it is a slightly safer drug than clarithromycin because there's less drug interactions. But again, we tried, one of the things we were concerned about is azithromycin prophylaxis, which we know is growing, and there are situations where that is very appropriate. So we tried to explain to GPs and remind them of when it was appropriate, and get them to try to focus on whether they felt that azithromycin prophylaxis should be continued in their patients. And we also explained to them that really it wasn't something that was appropriate for a GP to initiate, but if they thought, having seen this being prescribed for somebody else, that it should be considered for their patient, is to check the guidance. And we have, the ICGP has got a guidance document on this, a quick reference guide, which was drawn up in conjunction with the hospital respiratory lead. And we tried to promote the use of this and maybe get them to open a discussion if they felt a patient either should be on this azithromycin prophylaxis or perhaps shouldn't, that maybe they could chat with their hospital colleague about this. Next slide, please. And again, this just illustrates the same process. I'll move on just for the sake of time, Rob. So now just we get to now we're looking at the 2020 data, okay? So now we're looking at in the COVID era, and we have only very preliminary data. So what this shows is that the trends in terms of quality of prescribing are still there. So you can see comoxiclav going down, clarithromycin sort of staying the same, doxycycline going up. But unfortunately, the quantities appear to be really significantly higher for the GMS prescribing data. And that has alarmed me a little, but we only have the data for the top 10 at the moment. So the next slide, please. And here now we're looking at the same data, but we're looking for private and GMS. And here we actually see the opposite. So we're seeing that there is quite a significant reduction in overall antibiotics prescriptions brought to the pharmacy for dispensing. So January, February and March, they've both reduced. So those two figures, you know, maybe we were just seeing more GMS patients, maybe GPs were giving prophylactic prescriptions to some of their sicker cohort of GMS patients to have, and maybe if they had COVID, they were more likely to prescribe for them as a just in case it might help prevent their disease getting worse. And we're also conscious that there was a lot of telephone prescribing going on here. So the next slide, please. And again, this is April. So in from mid-March to April, I mean, the pattern of the way GPs saw patients switched, you know, hugely over to telephone prescribing and WebEx consultations. And there was a massive reduction in antibiotics presented to the pharmacies for private and public. But again, this is just going to be an artifact of COVID, so we won't be able to take this into account in the overall data. I'd like to think that maybe it might continue, but we don't really know. And the next slide, please, Tony. Or sorry, not Tony. I'm used to saying Tony because Tony's usually doing the next slides, Rob, for me. So again, we can see here that the quality trends seem to be there. So you can see amoxicillin, we're back now to the first quarter data. So the amoxicillin is down 21%, clarithromycin down 17%, and cefalexin is up, nitrofurantoin is up. So you can just see that although those positive quality trends are still going. The next slide, please. And we're nearly there now. Oh yeah, sorry, that was done earlier. Just skip that slide. That was the one we were going to block. So the new normal, you know, we now have virtual consultations. Out of our services are doing a huge amount of WebEx and telephone. We've actually had to introduce WebEx consultations. We've been doing an antibiotic quality improvement stewardship program in South Dock out of ours, but we were only tracking face-to-face consultations either in the centres themselves or on home visits. So we've just recently managed to get the data enhanced. So actually from a week ago, we started to actually track the prescriptions that are prescribed from these virtual consultations. We don't know how much of daytime general practice is going to switch to that. The amount of people being seen or even ringing out of our services absolutely plummeted. Whether that's going to bounce back, how much it will bounce back, how much that's going to change over the next next couple of months, we really don't know. So there's lots of areas where antimicrobial stewardship focus is probably going to have to change a little. And as you know, there's a scarcity of data about virtual consultations and antibiotic prescribing. And I think one of the things for us as a group, we need to focus on that hospital GP interface and where antibiotics are prescribed. So for the final slide, Rob. And again, I suppose this is what I ask GPs to focus on for the next number of months, and what they themselves can do to try to help control superbugs, and around the three key things: that they use less antibiotics, use more green antibiotics. That immunization, you know, I think it's just so important. One of the things we don't want is to have an uptake in, you know, measles outbreaks or pertussis outbreaks. Unfortunately, the immunisation data in Ireland is not actually being collated at the moment because public health are off doing other things. So they haven't actually been collating that data. we are currently undertaking a workload survey with GPs, and of the GPs that have replied so far, and we've actually had about 400 replies at this stage, they are all giving their immunizations. They haven't reduced giving immunizations, so hopefully immunizations may have not fallen off, and they've done a huge amount of work in trying to encourage mums to bring their kids for immunizations. And I suppose, you know, everybody knows, hopefully has got a lot better at stopping bugs spreading from patient to patient and from healthcare workers to patients. So again, the focus, as all of us here, is on keeping antibiotics effective for future generations, and everyone to take personal responsibility for what they themselves can do. So I'm going to leave it at there for the moment, Rob, and we'll come back to it in the discussions.
Okay, thanks, Nuala. Excellent as always. So again, if I remind people to just to please use the chat box function if you have any questions or comments, and we will. We've been keeping note of all the questions that have been coming up so far, and we will address them in the panel discussion at the end. So we move on then to our final talk. This is from Mary Philbin, who's the Chief Pharmacist with the AMRIC division at HPSC. Mary is again somebody who is probably known to all of us on this talk, who's been just at the forefront of antimicrobial stewardship in this country for many years. And Mary is going to shift the focus towards antimicrobial stewardship in acute hospitals.
Thank you, Rob. If you can move to the next slide, please. So I'd just like to start off by saying good evening to you all, and I hope with me being the final speaker, I'll still maintain your concentration for the next 25 minutes or so. So I would like to take the opportunity to thank the Antimicrobial Stewardship Insight team for inviting me to join their team a few months back, and it's a privilege for me to present to you now on behalf of AMRIC and the AMS Insight team. I think at this point in the COVID pandemic, it's a timely opportunity to have this session. As the previous two speakers, Tim and Nuala, have alluded to, the antimicrobial stewardship is more important now than ever, considering the unknown territory as such that we're in. Work patterns have definitely changed, be it via telemedicine or changes within the hospital setting. And it's time for us to refocus really and ensure that we progress effectively and efficiently in terms of the stewardship, both nationally within the AMRIC team and then locally for stewardship teams within the hospital setting or the community, whichever is relevant. So my talk really will be divided into three sections, and with the majority of it focusing on the results of the antimicrobial stewardship in COVID-19 survey that we carried out a couple of weeks ago. And I really want to sincerely thank you for your contributions to that, because you had very little time to get your responses back, and so many of you have replied. We'll talk a little bit about what has been achieved to date in terms of stewardship with AMRIC, and what our plans were going forward, and possibly now with the results that we've received via the survey, what we need to focus on going forward. Next slide, please, Rob. So as I said, thank you all for your responses. We had 98 responses, and a great reflection, I think, of all the disciplines that are involved in stewardship. Of the respondents, over 10% were infectious disease physicians, a quarter were clinical microbiologists, and almost a half were either antimicrobial stewardship or infectious diseases pharmacists. Next slide, please, Rob. And again, these responses were received from the spectrum of hospitals across the country, both public and private, with over 2/3 of hospitals responding. 100% of Model 4s participated in the survey, and over 2/3 of Model 3s and half of Model 2s. Next slide, please, Rob. 91% of the respondents have a formal structure for antimicrobial stewardship at their place of work, so are, as we'll say, well qualified to answer the questions of the survey. And it was found that 75% of respondents had significantly changed their antimicrobial stewardship in their workplace, with 3/4 having a reduction in antimicrobial stewardship rounds, and again, similar numbers having a reduction in other antimicrobial stewardship work. Next slide, please, Rob. And the key reasons for this change: 46% accounted for the change because of staff shortages for COVID-related reasons, or due to IPC restrictions in terms of reduced ward or chart access, reduced face-to-face contact for meetings or education, again due to the IPC restrictions. And then in terms of the other reasons for the change, were because of a prioritization of COVID-related workloads, or again on a similar theme, diversion of consultant microbiologists from antimicrobial stewardship work to IPC work. Next slide, please, Rob. In terms of your perception of how you viewed the effectiveness of antimicrobial stewardship both before and during COVID, this slide demonstrates that answer, and we're looking at a scale of 1 to 10, so 10 being the most an extremely effective antimicrobial stewardship program. So if you look at the top bars on the graph, that's the overall response from all respondents, and the your stewardship program was rated up at 7 prior to the pandemic, and that significantly dropped to 5. Again, we looked at this across all of disciplines involved in the stewardship to see if there are any differences, and really they were broadly similar. So this is confirming to us that the pandemic has had a significant effect on stewardship programs. Next slide, please, Rob. When we look at what the unexpected events or occurrences were in terms of stewardship, looking at specifically at antimicrobial use, there were decreases in the prescribing antimicrobial prescribing policy, and then a lot of increases, and that with increased use of restricted antimicrobials, broad spectrum agents, multiple agents being used. Increase in consumption of antimicrobials was seen to be increased despite a decrease in patient numbers, and an increased use of once daily antimicrobials, with ceftriaxone being an example, and 2 respondents reported increased C. diff as a result of this. There was also changes noted in meropenem use. Next slide, please, Rob. And also what was noted was that there were increases in MDROs. Respondents reported decreased screening for MDROs, so as to whether that is a result of the increase seen in MDROs or not, and the decreased screening was explained because of decreased patient screening or changes in workflow within the lab in terms of processing. A positive effect noted was the increased use of biomarkers to assist in antimicrobial stewardship, so in terms of urinary antigens and procalcitonin, and hopefully we'll get to talk a little bit more about procalcitonin, and there's been some discussion on the chat I note earlier, so hopefully we'll carry that through in the questions and answers section. In terms of the experimental agents, again, this brought about high volumes of queries, adverse drug reactions in patients, and some hospitals reported prescriptions of agents not available in Ireland. And again, this all has a time impact associated, and possibly detracting from the regular antimicrobial stewardship work. Medicine shortages and supply issues were noted from hospitals, and challenges associated with the communication, and be that in terms of change in work patterns with the frontline primary clinicians, new doctors joining teams, and respondents noting that there was reduced sharing of information between local teams. Next slide, please, Rob. In terms of stewardship interventions that were introduced that were particularly effective, there's a few I would just like to highlight. Again, mentioning procalcitonin. One hospital disseminated an antimicrobial stewardship teaching video via WhatsApp. So again, if people would like to share more information on the chat function, that would be very valuable. And the use of, again, virtual communication between IPC teams, pharmacy teams, etc., was something that was particularly effective. Next slide, please, Rob. I'd like to just highlight some interventions that were shared specific to the COVID patient cohort. So some hospitals used the antiviral treatment guidelines and took it a step further and restricted the suggested agents, depending on the version of the guidelines, to microbiology, infectious diseases, and respiratory clinicians. Some used pre-authorization prior to the initiation of these agents. Some hospitals carried out a clinical review or stewardship rounds of all COVID positive patients and reviewed accordingly, promoting IV to oral switch to reduce contact times for frontline staff. Other hospitals followed up on their COVID negative patients and reviewing antimicrobial therapy accordingly. Next slide, Rob. In terms of taking antimicrobial stewardship forward in your hospitals, what are hospitals proposing to do? Is there going to be potential discontinuations of some of the antimicrobial stewardship services? I think this slide is very encouraging and shows us that 50% of hospitals are planning to continue all of their antimicrobial stewardship activities. And if you look at the third bar down, which is the other, a lot of comments within the other reply was that most hospitals would hope to resume all normal antimicrobial stewardship activities as soon as is feasible, but there may be a requirement to drop one or two things accordingly. If interventions are to be dropped, the types of examples that were given were face-to-face education, antimicrobial stewardship rounds, and audit of antimicrobial use. Next slide, please, Rob. Nuala mentioned in her presentation the antimicrobial stewardship and COVID statement that we published towards the end of April. And just to give you a little bit of background to the publication of this statement, really the stimulus was a 24-hour snapshot that we carried out prior to issuing version 3 of the interim guidance on antivirals. So we had a look at what was being used on the ground for the COVID inpatient population in terms of antivirals, but we also looked at antibiotics. And of those who replied, it appeared that 85% of the COVID inpatient population were on antibiotics. A literature review at that time informed the statement that secondary bacterial infection appears uncommon in the COVID-19 patient population, which I think concurs with the findings presented in Tim's first presentation earlier. As Nuala said, we try to encompass all the care areas to ensure a consistent approach across primary and secondary care in terms of the use of antibiotics in this patient population. We also used it as an opportunity to highlight the consideration of other serious bacterial infections in the differential diagnosis. Because COVID was having such a high profile, we didn't want other serious infections to be overlooked. We asked a little bit about this in the survey to get your feedback on this statement and how we can increase the impact of it. So encouragingly, 92% of respondents were aware of this guidance and 61% had implemented it in their hospital. Next slide, please, Rob. In terms of the actual impact then of this statement, overall 26% of respondents felt that it had an impact, and of those 26%, half felt that there was a reduction in antimicrobial use. Again, we broke this down in terms of the disciplines as to what their perceived impact of the guidance was. And again, in contrast to some of the other questions that we broke down by discipline, this actually varied quite a lot. So I think there's definitely some more work that we need to do in terms of this statement. If you can move it on. Next slide, please, Rob. And you have provided us some very valuable feedback on that. So this is something that we'll definitely take forward. One of the suggestions was to tailor the stewardship statement to the various settings. While initially we had tried to encompass all, I think we're at a stage now where we need to tailor it to the individual settings. And again, based on Tim's talk, we may need to even differentiate the hospital, say, setting further into the critical and the non-critical care setting. Next slide, please, Rob. Some further thoughts that I want to highlight. I'm not going to go through all of this, but what you have kindly shared with us is that really the COVID pandemic and the delivery of stewardship in the hospital setting has highlighted the value of electronic prescribing, electronic resources and technology to conduct remote antimicrobial stewardship activity. And hopefully we'll get to talk about that a little bit later. And the stress associated with balancing all the demands is a theme that has definitely come through in terms of staffing, IPC, AMS. And another positive, I think, from this pandemic is the huge amount of collaborative work that has developed both locally and nationally that has been very positive and I think has had a positive impact on stewardship. Next slide, please, Rob. Some of the challenges that you have shared with us going forward is that there's the possible lack of resources, that our resources redirected to IPC, the physical distancing, the issues that poses for the stewardship, and the increased need for electronic prescribing and virtual ward rounds. Next slide, please, Rob. So, back one. Thank you. I would just like to share a little bit with you on how we developed the investigational antiviral agent interim guidance. Again, I have mentioned the fantastic collaborative working, and again, I think this is a really good example of how that collaboration has worked on producing very timely national guidance. There's been engagement from a wide variety of groups that I've listed there on the start, and again, depending on the needs of the guideline and the requirements, various national clinical leads within the HSE have stepped up and become involved in that guidance. A key part of the being able to get the guidance out as quickly as possible was the work of the evidence review group, which was stood up at the start of the pandemic, and this encompassed evidence synthesis practitioners from the Medicines Management Programme, NCPE, and the NMIC, and I think their work on frequent updates of the evidence has led to the credibility of this guidance. I have to say it's been a very intensive process to keep that guidance updated because of the rapid change in evidence, which required rapid turnaround in versions. I do think it has given us a very usable framework for going forward for other national guidelines. And within AMRIC, we're working on developing proposals around how we would frame further national guidelines based on this approach. So what did you actually think about the guideline? We'll move to the next slide and share that information with you. So looking at the graph on a scale of 1 to 10, you can see that the usefulness of the guideline was rated quite highly, and again across all disciplines. So that's very encouraging, and I think almost a sigh of relief that all of that work has been of some use to you. Next slide, please, Rob. And again, you've provided us with further suggestions as to how we can improve that guidance, but noting that 2/3 have no suggestions to improve. And I'll bring those suggestions to our guideline group we're meeting later on in the week because of the information that has come to light on the hydroxychloroquine. So that will be reviewed at the end of the week. Next slide, please, Rob. And again, thank you for your suggestions that you would like more national guidance similar to that interim guidance, and that it would be available in a readily accessible platform or app for smartphone use. So that's definitely something we can consider. Next slide. And the types of guidance that you would like to see are respiratory tract, skin and soft tissue, intra-abdominal UTI and surgical prophylaxis. And some of those is are what we would have had on the work plan already. So it's encouraging to see that we are working to the requirements of the local stewardship teams. Next slide, please, Rob. I've summarised the survey responses over the next 2 slides, but we can skip over them if you don't mind, Rob. I've included a summary here of the antimicrobial stewardship work that we have undertaken with AMRIC since I came into post, which is just less than 10 months now at this stage. And this is absolutely not taking away from all of the antimicrobial stewardship work that has been done, I suppose, since the publication of SARI back in 2001. There's been a huge amount of stewardship work done in Ireland since then. So this is purely a focus on the work that I've been involved in my role since commencement. So the National Guideline on Treatment of Carbapenem-resistant organisms, and we published subsequent advice on meropenem verbactam. And again, just you may not be aware, we are maintaining a database on the treatment of individual CPE bloodstream infections and the agents that are being used, and hopefully use the data associated with that to inform further versions of the national guidance. A few months ago, we established the Antimicrobial Consumption Subcommittee of AMRIC, and the terms of reference of this committee is to ensure a comprehensive data capture, interpretation, reporting, benchmarking and analysis of antimicrobial consumption in all sectors of human health in Ireland, with the aim of informing the antimicrobial stewardship work. And we have representation from community, hospital, HPRA, and various other stakeholders. And one of the items that we would discuss at this is the PCRS green-red reports that Nuala would have referred to earlier. So we decide on the theme for the next report based on a review of the data. And that's just one example. We would also talk about the hospital consumption data, the national point prevalence study, etc. Next slide, please, Rob. Some of the work that we have in progress, so just to let you know, in terms of the HSE community operations side, we have antimicrobial pharmacists taking up post in each CHO over the next couple of months. So just for you to all be aware of that. Some of the areas will be colleagues that you have already worked with in the hospital setting. They're extremely experienced individuals that are taking up these roles. So I would hope that you would maintain those close links with those individuals that you already have. And the antimicrobial pharmacists are going to be led by Bernie Love, who's taking up the chief pharmacist post in community operations. And they will be working off a national antimicrobial stewardship plan with it feeding in then to each CHO. There has been work done with community pharmacists in terms of scoping out what their capacity and requirements, educational requirements in terms of stewardship, and that's a piece of work that I'm progressing with the Irish Institute of Pharmacy. We have our surgical prophylaxis work progressing, however, that was halted with all the competing demands of the pandemic, so I would hope that we would get that back on track sooner rather than later. In terms of we have some limited funding available to us until the end of 2020, and we have prioritised that to assist the Model 4 hospitals in increasing their antimicrobial pharmacist staffing levels to 2 whole-time equivalents. So we are slowly working up with each individual hospital and prioritising those with the lower WTE. So if you haven't heard from us and you're a Model 4 and you're not at 2 whole-time equivalents, again, over the next couple of months, we will slowly be assisting you in that. Next slide, please, Rob. Because of our mutual interests in hospital consumption and prescribing data, I've taken the opportunity just to include a brief summary of the results from the point prevalence study in 2019, and then the consumption and the further 2 slides. So I'll quickly share some of the key points from that with you. So for 2019 point prevalence study data, almost 40% of hospital inpatients were on antimicrobials. This was a slight increase from 2018, and the 2018 figures are in brackets, as you can see. A third of patients are receiving their antibiotics via the IV route. In terms of the agents that are prescribed, there's been very little change in the order of that. The most notable changes are that clarithromycin has decreased from 5th position to 7th, and meropenem has increased from 13th to 9th. So I think they're notable changes. Over a third of prescriptions are for coamoxiclav and piperacillin-tazobactam, and that's a slight increase on 2018, and again, nothing that we're surprised at there really. The third most commonly used agent is metronidazole, and we looked into this a little bit further, and even though it's an agent of excellent oral bioavailability, 70% of its use is IV, and 42% of its prescriptions are in conjunction with another anaerobic agent. Despite all stewardship teams, I would imagine, speaking of no requirement of its use in conjunction with another anaerobic agent. There's been improvement in the duration of surgical prophylaxis prescribing again, which is encouraging. Next slide, please, Rob. So in terms of, we discussed this data in detail at the last antimicrobials consumption subgroup meeting, and the actions that were agreed at that we would prepare a report for the HSE AMRIC oversight group. We would hope going forward over the next couple of months to focus on the use of piperacillin-tazobactam in terms of consumption, and hopefully that we'll have some more frequent consumption data available to you again. But the pandemic has really put a stop to a lot of this work, so hopefully we'll get back on track in the next couple of months. I hope to prepare an education piece on metronidazole that I will share with you, and feel free to use, and we hope to publish that in our Resist newsletter and Epi Insight. A poster of the point prevalence study has been prepared by the following individuals, and that was hoped to have been displayed at ISCM, IDSI and the HPI conferences, which unfortunately didn't go ahead. So for those of you that are interested, that poster is available on the HPSC website. Next slide, please, Rob. And this is the hospital antimicrobial consumption surveillance data. This is provisional data, it's not fully finalized. There's some further analysis, but just to share with you some brief points. There's been a reduction in fluoroquinolone use. The carbapenems have shown a consistent decrease since 2016. Oral clarithromycin is actually contributing quite a significant use to the overall rate. So it's just something to highlight and bear in mind. And for the consumption reports going forward, this will be incorporated with the individualized decile score, so you'll see how you compare to other hospitals. So that may assist in drawing attention to it, because there is a wide range of its usage. So the median rate is 6, but there is a range up to a maximum of 14 within hospitals. So it is very variable among hospitals. Next slide, please. So I'll leave you to look at the other information in the interests of time, and assisting with giving sufficient time to discussion now. So to finalize, really, thank you all so much for your informative replies in the survey. What I would like to say is that we will definitely take all your suggestions on board. We would hope from the AMRIC perspective that we'll be able to give you a helping hand, and I think definitely what's coming through is that the electronic solutions are highly desirable in the current working era. We will. Something I didn't talk too much on earlier was the definite need for electronic prescribing. While AMRIC will not be able to deliver on this, I would like to tell you that we will, but I would hope that we will do our best to keep it on the HSC agenda. So thank you for me, and thank you to a lot of individuals that have helped me in putting this presentation together. And I'd also like to thank all of those collaborators that have assisted in the various guidelines and work over the last couple of months. Thank you.
Okay, thank you, Mary. So again, it was a great overview, and thanks so much for putting the survey data together so quickly. So we are going to move now to our panel discussion. And so in addition to our speakers, we're also joined by Professor Martin Cormican, who's the HSC lead for antimicrobial resistance and infection control. And we also have joining us are some of the AMS Insight organization panel as well. So I just want to kick things off, because one of the, just looking at the questions and the comments that have been coming through, one of the sort of common themes has been around the use of technology and telemedicine, and certainly one of the things that has struck me is there's things that we've been looking for in terms of remote clinics and use of digital systems that we've been looking for years, and suddenly they've been put in place in the space of just a month or two. And as our Chief Operating Officer always reminds us, never let a good crisis go to waste. And I think we've seen some really good examples here. And I wanted to put this out to the panel in terms of what you see as the potential benefit of telemedicine and technology in terms of antimicrobial prescribing, and perhaps are the potential downsides as well. And maybe Nuala, we'll start with yourself.
Yeah, I mean, telemedicine and telephone consultations, I think, have got a very potential significant role to play in how we deliver general practice. But I would certainly very much argue probably against them where patients are sick. So I would see telemedicine as having a significant role to play in the management of chronic medical conditions, in touching base with people who, say, suffering from psychological illness, in perhaps planning consultations, so things like, a menopause consultation. So you could do a lot of the sort of having a pre-consultation. You might end up somebody coming in for a targeted certain set of tests or examination, and then you could have you can follow up, as we often do by telephone anyway with some of them. But I would be very fearful about things like urinary tract infections being handled by telemedicine, kids who are sick. I think in terms of antimicrobial stewardship, I think you could be on a very slippery slope, very easy perhaps to prescribe. And we know what's happening already. I mean, this was an issue pre-COVID. People were actually able to ring services in the UK and get a prescription emailed to pharmacies here, for antibiotics. So I'd be a little bit fearful about its role in terms of antimicrobial stewardship and impacting adversely on it.
Yeah, and I'm curious if any of the panelists from the hospital perspective, if this is something, have you seen something similar in terms of the impact of remote clinics and potentially remote prescribing?
Hi Rob, I certainly think that we've seen some increases. I think at the moment probably just anecdotal data, but for some of our patients with more complex infections, so osteomyelitis, prosthetic joint, there seems to be a concern between both hospital care and primary care that because the patient isn't getting to a clinic where they're being physically seen, examined, getting bloods, I've seen that people are getting extensions of their antibiotics even though they've gone well beyond the recommended time course. The patient had been getting on fine within the recommended time course of the prescription. I don't see a clinical reason for those prescriptions to be extended other than general anxiety and trying to practice medicine by telephone for those complex patients.
Mm-hmm. Yeah.
And do you think it was just a temporary thing, Geraldine, you know, just sort of to get through a particular period of time? Because I think there was a 6-week time period there where I think a lot of things most people probably feel wouldn't be their normal way to do things. They had to do because they couldn't get somebody in. It was sort of a kick to touch.
Yeah, I suppose I'd hope that it's temporary, but only time will tell.
Yeah. That's what I would feel about it a bit.
Yeah. I mean, it's interesting, in particular, I think from the sort of a pediatric perspective, is how much of the changes that we're seeing is due to changes in biology, because we just simply we've less viruses and less bacteria being transmitted in the community. And we've seen in terms of the invasive bacterial pathogens that we track in the reference labs, like meningococcus, pneumococcus, and so forth, they've all dropped by about a third. But then there's also behavioral changes as well. So people are less likely to come to hospital. So we're seeing less children with sort of perhaps trivial infections turning up in hospital, but we're also seeing children with more severe infections presenting later. So we're seeing, for example, surgical colleagues have sort of said, you know, they're actually operating on more children with appendicitis because they're seeing them later. So because the parents aren't bringing them initially. So paradoxically, that's had a beneficial impact from an antimicrobial perspective, because they're being operated on and they're only on antibiotics then for 24 hours and going home. But from just a general patient management perspective, it's a worrying trend. So I'm curious if anybody has seen that sort of interplay between the kind of the biology and behaviour and how it's impacted stewardship.
I think another thing which has been said at a few ID conversations is that because of the lack of availability of dentists during that 6 weeks, we've seen more people present with head and neck infections. And I wonder if other people have had a similar experience.
Martin, I don't have any similar experience, but I think that's really useful, and if it's possible to get any information on that, it might be very helpful, because the whole process of getting dentistry back up and running was quite complicated, and one of the issues that was discussed was the amount of morbidity that was involved by the suspension of dentistry. So if there's any information on that, it'd be really useful to have.
Yeah.
So another theme that came up in a couple of the questions was around the use of biomarkers, and particularly procalcitonin. Now, I've had very limited experience. We've only recently started to use it in Temple Street. We've had one patient with COVID in our ICU who we did use PCT to be able to reassure some of our colleagues that yes, we can stop the antibiotics. But I'm curious if anybody else has any experience, or Tim, I don't know how extensively it's being used in the UK.
So I think in general in the UK, procalcitonin is something that's been fairly slow and only used in specific hospitals and situations. But I think one of the possible benefits of COVID has been actually that a lot of hospitals have now implemented it during the pandemic. So in terms of our experience, I think it was set up and implemented by sort of early April, the middle of April for us, and we started using it just as we sort of hit the peak of cases within our trust. So I've spent a lot of time in ITU recently, and it's been really helpful there actually for us in terms of just trying to have some confidence in stopping or de-escalating therapy in patients who, still having evidence of cytokine release syndrome, so they're still having fevers, high CRPs, they might be on steroids and have deranged white cells, and obviously are in a bit of a mess in terms of respiratory secretions and possibly having positive microbiology, but you're unsure whether it's contaminant or not in someone who's been intubated for several weeks. So I think it's been really useful in that perspective. I think from my own personal experience, it was a little bit late coming in for us in terms of the general hospital, just because by the time it was in, we were having a sort of large surge in cases, and we didn't really have a sort of a firm grasp on how to get people to use it in terms of getting one on admission and serial trends. So it was often quite ad hoc. But I know that there's a lot of work going on behind the scenes now to try and integrate that more into our practice. And I'm really hopeful that now we've got it implemented within the hospital, that it will have a more long-term benefit also. Because I think, particularly when we were seeing sort of a surge, you know, the pretest probability, everything was coronavirus that was coming into hospital, and there may be bacterial co-infections, but now we're down to lower levels as well. It's becoming more important to be able to differentiate early in terms of bacterial and viral infections as well. So whether it will sort of actually have a better impact now that we're seeing less cases of COVID also in terms of our stewardship and being able to de-escalate early, you know, it's still to be seen, but it's something which we're catching up with in the UK now. And I think it's been thanks to coronavirus and that diagnostic dilemma we've had in terms of using things like CRP traditionally, that's really driven that.
There was one sort of specific question actually that arose just from Nuala's talk around the sort of prescribing community, that Ed Smith was wondering about, you know, should laboratories be reporting phosphomycin susceptibility for GP urines? Now I know, Nuala, you and I, and I think Mary, we were involved in this as well. In a previous life, we looked at this in some detail, and the upshot of it was that the answer was yes. But I'm curious to see what others on the panel think in relation to that.
Yes.
Yeah, I suppose it's one of the things that we have done now is actually we've changed phosphomycin in the community prescribing guidelines to second line. It was a first line. And I suppose always the query has been I know microbiologists tend to differ on this, and some microbiologists feel if we start to use phosphomycin, then resistance will start to develop. And I think has been a little bit of early indications of that, and they wanted to reserve, and I know there are different compounds of phosphomycin, they wanted to keep preserve and do nothing to interfere with the intravenous phosphomycin that you use in hospitals. That was my understanding around it. But so I don't know, is it that it's just not being reported, or it's not being tested for in general in hospitals in Ireland or in laboratories in Ireland?
Well, I think most hospital laboratories now will have it as part of the panel for your susceptibility testing, and then it's just a question of whether it's reported or not. I mean, I know at the time when we looked at the data on this, in terms of the impact of the oral phosphomycin formulation, and particularly in countries like France and Spain, where it's been, you know, sort of a primary workhorse antibiotic for UTIs for decades, and they haven't seen emergence of resistance. However, when you look at the data for the IV formulation, you see hospitals that use the IV formulation, that's where you see the rapid emergence of resistance. So it does seem as if and paradoxically, I know when we looked at this at the time, there was a sense that actually if you increased the use of phosphomycin and reduced the amount of cephalosporins and other beta-lactams for UTIs, you would paradoxically actually likely see a reduction in drivers for ESBL and other resistant gram-negatives. So certainly, I mean, as Martin summed it up, I'm on the yes yes camp for that one. So.
Rob,
yeah,
could I ask a question? Because I haven't been keeping up with this, so this is a question out of ignorance, and as simple as that. The whole PCT CRP debate? Has that sort of progressed to the point where everybody is now satisfied that PCT is better? Or because the last time I looked into it, which was a couple of years back, it wasn't all clear to me. So I just, so as I said, it's a question that arises. This is a please save me reading literature question.
Yeah, I think the short answer is yes. I think we look at the performance characteristics for sort of PCT versus CRP. The PCT has is far more sensitive and specific for bacterial versus viral infection. And certainly, I know in peds, there's a lot of areas now where there's very good data, and I know I have colleagues in maternity hospitals that are using it routinely now for determining antibiotic duration in neonatal sepsis. So I think as we gain more experience with using it, it's interesting if you go back and look at the NICE guidelines in the UK on sepsis and on particularly on bacterial meningitis. In their evidence review, they very clearly show that PCT is superior, but at the time they said no, but continue to use CRP, and it was actually down to just a cost decision, because at the time laboratories weren't well equipped for doing PCT. But I think as the cost has come down and the availability of more sort of accurate, close to patient testing, I think we're definitely seeing a shift.
That was my question. Is there a near patient version of procalcitonin available now? I don't know either, Martin, like that now. I at one time I was very au fait with all the ins and outs of it, but I know that HICWA did do a health technology assessment on the use of CRP in reducing antibiotic use for respiratory tract infections in general practice. So I think maybe that whole procalcitonin, because what struck me, Tim, as well, you were talking about the bacterial co-infection in non-COVID viral pneumonia, and I think you quoted one of the studies. It was about 11% being the data there. And we see every year on year, we see this rise in antibiotic prescribing during the viral seasons, during influenza and RSV and everything is circulating. And really, if we had some near patient way of being able to say, you're most likely to have a viral or you're most likely to have a bacterial infection, I think that's in terms of the community where 90% of the antibiotics are prescribed, that's just crying out for something good that would do that easily, simply, cheaply, and preferably without sticking a needle in a child.
So, I mean, in terms of procalcitonin and sort of more near patient tests, there are some literature reports around different types of biosensor technology, which have been developed for procalcitonin. But as far as I'm aware, none of them have been moved into or tested as a proper sort of patient point of care test at the moment. But there are a range of different aptamer technologies, for example, which have been selected for procalcitonin. So I think that there's probably a move towards that. But in terms of biomarker and drug monitoring in general within the infection sphere, it seems very behind other areas in terms of those point of care tests. But no, so in short, in terms of procalcitonin, there are described papers of different biosensors which appear to be fairly sensitive and specific, but I'm not aware of any commercial products yet which have been taken forward in terms of those.
I suppose they probably won't be taken forward unless there is reasonable certainty that healthcare systems are actually going to use them and pay for them to be used. And I think that's probably been, antimicrobial stewardship and infection control have tended to be a little bit of the Cinderellas in more, recent, until more recent years in terms of funding. So,
I mean, that's been the thing that's. Oh, sorry, Robert.
Well, yeah. Sorry, if I had to.
I was going to say that's always been the thing that struck me about procalcitonin in general as well, in terms of some of the initial larger sort of randomized control trials in community-acquired pneumonias. They showed you could reduce your length of antibiotic therapy in CAP down to 5 to 7 days. But in a similar New England paper, there was also one showing that if you just stopped antibiotics at 5 to 7 days, you had very similar outcomes. So then it always becomes a kind of a behavioral factor, isn't it? What's easier to help to nudge someone towards stopping therapy or prescribing shorter course therapy in those situations.
Yeah, no, I agree. I think it always comes back down to behaviour. So Geraldine, I saw you had your hand up there.
Yeah, no, just I saw a paper within the last week or two. I think it was open forum infectious diseases. I may be wrong about that, but they were looking at PCT and the findings in people admitted with bacteremias. They actually found quite a high rate of false negatives, and the overall conclusion I think was quite a sensible one, that interpret with caution.
Yeah, I think certainly in the hospital setting for stewardship, I think the role is generally is in sort of determining when it is safe to stop. So it's sort of and actually I just noticed from this Emer Davenport had asked about, you know, an ideal time to perform a PCT test. The way that I tend to look at it is that PCT gives you some sense of what's happening today. CRP tells you what happened yesterday, and so it's what it's really doing is it's just shifting that time frame. So I'm just conscious of the time. We're nearly at the end. So were there any other particular issues that anyone would like to raise? And can I also remind people that there is just a questionnaire that has just popped up, a sort of end of session poll that I encourage people to please answer as well, because it just really gives us a lot of help in terms of planning for future events.
Rob, could I ask a question actually of the panelists? I know one of the areas that I am concerned about is antibiotics that are prescribed in the emergency department or antibiotics that are prescribed in the outpatient. So I am not sure that we're capturing this data, or is there any way of actually capturing the hospital initiated prescriptions which are then transferred onto a patient's community prescribing? So they're initiated in the hospital, but they're appearing in the GP data. And I think moving forward, I think it's an area for antimicrobial stewardship that we do need to consider how we could, as a group, how we could actually target that.
Yeah, I completely agree, and I think there's two aspects to that. One is the surveillance aspect in terms of, you know, how, you know, is it possible to kind of flag those prescriptions, or, you know, where the kind of the primary source of the prescription was, even if it is then subsequently counted under the community. And then the second thing I think is going back to the theme that's gone through a lot of the talks and discussions is around the use of technology to help to link you know, prescribers in hospital and the community as a way of actually sort of addressing these issues.
My name is Marie. I've a background, I'm a pharmacist with a background in AMS, and I work in clinical informatics now. So I suppose now working on the electronic side of things, the data that you can pull from an electronic system is fantastic, and it's that real-time data, I think, in Ireland that we really lack currently.
Your sound quality isn't great, Anne-Marie.
And I suppose there's very few settings in Ireland that have an electronic outpatient scrapings at home, and I know James advice. But I suppose ultimately, I think as a pharmacist and with a person in a background in AMS, I think what we need is to try and capture the data
So something like a central electronic prescription service, whereby you're similar to the NHS, where your hospital and your community setting are feeding their prescriptions into a centralized service where we can audit and pull the data and real-time data and feedback to prescribers. And I think we can pull the data in hospitals and we can pull the data in community, but what we're looking for, and I think it's often a gap in AMS, is an overall picture of what's occurring against the other. So I think there's, as Mary has said and everyone has mentioned, I think the COVID, if nothing else, it has really highlighted the advantages of putting electronic prescribing services and the real need going forward in the HSE of moving everything over onto an electronic platform.
Okay. And sorry, I know Mary, I think you had your hand up there as well.
Yeah, I just wanted to mention about the prescriptions from hospitals. They should flag on a GMS database as hospital emergency prescriptions. So it shouldn't be, especially for GMS ones, so it shouldn't be that difficult to pull data. And if pharmacists and community are inputting prescribers correctly, they should be flagged as hospitals rather than a GP. Doing an audit of discharge prescriptions just from St. James's perspective is something we're kind of looking at for our future plans. But obviously, one hospital that has electronic prescribing isn't going to be representative of all the acute hospitals.
Okay,
that's very interesting, Mary.
We have, yeah. So
in terms of electronic prescribing, Rob, one of the single biggest positive silver linings for general practice was getting rid of the dot matrix printer. So for years, I've had this, I'm actually going to sue the HSE, I think, for noise-induced hearing loss. This thing, and it goes, you know, so if you're trying to do a 6-month prescription for somebody, it usually spits out 12 versions of it. So it's trailing along the floor, and then you've got to fold this all up, sign each one of them, and then give them to the patient. So for years we've been trying to get this electronic, and we now have, direct from our software systems, we can actually email the pharmacies via health mail, totally secure prescriptions. And so it's wonderful. And there are videos on Twitter of GPs throwing the dot matrix printers out the top of their buildings and watching them crash. So that's one of the big silver lines, because Rob, you were saying what were the things that really positive things. That's one absolutely 100% positive thing from the COVID era. Sorry, I think Elmary's trying to ask me something. Yeah, I think Elmary, you had something in the chat function. Can't you?
Sorry,
Elmary, you're breaking up. But I think you in the chat function you were wondering about us wanting electronic analysis of electronic prescribing.
Past COVID, people want. Yeah, no, you take that back.
I'm sorry, I can't say it really. I can't hear. I don't know if anyone could hear it.
Great, no. Sorry. So I think, folks, we are actually at the end of our time. So and I think the image of dot matrix printers flying from the roofs of surgeries is a really positive one to finish on. So I would like to thank our presenters, Tim, Nuala and Mary, but I'd also like to thank all of our organising committee, and particularly to Orla, Sherlock and ICGP for facilitating this and the sort of technical know-how to bear. And I'd also particularly like to thank Alida, who, as always, has just put tremendous work into organising another very successful AMS meeting, and hopefully next year we will be meeting again, but this time in person. So thank you everybody for joining in and for all of the valuable discussions.
Thanks.
Thanks very much.
Thanks, Rob.
Bye now.
Thank you.
Thanks, everyone.